Good morning to you all, doctors. This is NK Prasad welcoming you all for part 6 of 7 series webinar. Our sincere thanks and gratitude to Synergy Specialist and R of America for sponsoring this event. Today's topic is going to be on endodontics. I'm very much honored to introduce the speaker for today, Dr. Mohammad Sirjani. He is a certified endodontist through National Board of Dental Examiners. He received his dental degree from Manila, Philippines. Later on, completed his endodontic program from University of Southern California School of Dentistry. He is a part-time faculty member teaching endodontics to dental students and also residents. As a volunteer through Lions Club, he attended 11 mission trips to provide dental services to needy people. Dr. Sirjani enjoys skiing and also is a great piano player. Playing Iranian classical music. Today's presentation is going to be a little bit different. It will be somewhat similar to TED Talk. For half hour, Dr. Sirjani is going to give us a lot of tips, a lot of practical points. And now you could ask any question relating to endodontics. Any endodontic related question, feel free to post it on our chat box. Dr. Sirjani will answer pretty much all the questions. Dr. Sirjani, all yours, sir.
Good morning, everybody. It's great to be with my Indian American fellow dentist. It's a pleasure to talk with you guys. I hope this is somehow helpful for you. I'm sure you know so many of these topics that we're going to touch on. Just to give you a brief introduction about myself, my name is Mohammad Sirjani. I'm an Iranian American dentist. Got my early education in dentistry in Philippines, Manila, Central Escolar University. Then I moved back home in Tehran, which I practiced the general dentistry for almost 7 years. Opened up my own office. I had another office in the suburb of Tehran, which other general dentists helped me to run it. Then got passionate for endodontic science and moved back to the United States in 2013. Passed all the national boards, everything, and joined the Advanced Standing Program for International Dentists, which granted me the DDS of the United States at USC. And later on, I was one of the lucky ones who got into endo program right away and finished my education there. My mentor is Dr. Rafael Rojas. He was my program director. Whatever I learned from him and his fantastic faculty at USC. And I hope this will be a useful talk for you folks. So basically what we're going to talk today and see diaries and things like that, they're going to actually be mixed up together. It's about the business perspective of that. They're talking about the offices that they require services of an endodontist, or whether they're thinking about it and they want to evaluate whether it's a good idea or not. So I'm going to tell you the perspective on endodontists when they go to certain offices. So in my opinion, these are my, if I quote something that is scientific, I will let you know the scientific code, but otherwise it's my humble opinion. So in my personal opinion, we have 3 different kind of endodontists in the market right now. Some of them that they have their own private offices. They are fully all the equipment, microscope, CBCT, anything that an endodontist can ask for. And they have the luxury of spacing their patients. They see between 2 to 4 patients for treatment, which is the ideal of any scenario. I'm never going to argue with that fact that it's a much better treatment route, and that's the best service that any patient can ever get. So that being said, but we live in a real world, so not everybody can seek out the help of an endodontist to go to their office, or not everybody can afford to see them. And not every single business wants to refer their patients out. This is as important as patient care is. Again, it's a business that people are running. So the second type of endodontists are the one who do something in between. Basically, I go the third person. The third option basically are the ones like me who are traveling endodontists. I cover so many different offices, and among them there are endodontic firms, there are private offices, and there are the DSO setup, as all of us know, like Pacific Dental, Gentle Dental, so many of them are in the United States. The second group falls in between. They're not the one that have their own office, but they do not like to do certain amount of cases. They usually like to do 4 to 6 treatments per day, and they are comfortable with that range. So when I get reached out by companies such as Synergy or private offices who seek out and they want to see if they can bring someone like me in, usually I ask them a few questions first to understand their need and to understand their offices better. Basically, what I always ask them is to look at their data first to see if how many cases of endo they've been either doing or referring out. The minimum number for someone like me, for instance, that makes it something that I can think about going to that office is minimum 6, 7 cases to make that day an endo day for that office. Some offices, again, the question that I ask, how many chairs do you guys have in your office? If they say we only have 4 chairs, basically that's a day for only one dentist or a specialist to be work at the office. If they have multiple chairs, usually some offices that I go, they do have their general dentist working at the same time, their hygienist and me. It rarely happens that they bring 2 specialists together because when an endodontist or oral surgeon or somebody goes to a busier office, we require 2 to 3 assistants to be at our site. And again, there are different setups. Some places they like to offer their own assistants. Some of them we can recommend some assistants through, of course, companies like Synergy, which they can provide the assistance as well. So whenever I'm trying to go there, I ask the general dentist, do you guys do any kind of root canal treatment yourself? And if the answer is no, well, no problem. I'll do all of them. If the answer is yes, I'd like to know what cases are being referred to me and what cases are being done by the general dentist. First of all, I am a big supporter of general dentists doing root canal treatments. So I think you guys are very well trained for it when you were in dental school. And some general dentists throughout the experience, they have found great skills of taking care of their patients. But we are the best judge of our own. We know our limitations and we should know what the expectation should be. So I always talk about case selection with what cases should be done by general dentists, what cases should not be done by general dentists. And the second case selection, what cases should be done by an endodontist in a general dentist office and what cases are not to be seen by even an endodontist in a general dentist office because of lack of instrumentation, technology such as microscope, CBCT, and so on and so forth. So let's talk about case selection a little bit. The case selection usually follows by a good diagnosis. Diagnosis is a very, very important part of any specialty, but in particular in endodontics. Mostly people who end up in a consultation chair of an endodontist, they are either having pain, they're having infection, or they're not having any symptoms. Something has been detected in a radiograph or a routine checkup, or patients saw something abnormal in their mouth. They address their dentist and then they're out to be seen by me to explore that option to see if it's something needs to be done or not. Pain and infection usually goes towards the emergency cases. Again, the emergency, we have to see, is it an urgent care emergency or is something that could be wait until somebody see them? Basically, if somebody is in a severe pain that could not be tolerated, or they think it's a life-threatening situation, those that call 911 do not wait for anybody because we don't want anybody's life to be jeopardized. We don't know what the underlying condition is, what is causing that pain. But if it's something that could be managed by medication, or if a patient comes to a general dentist office and they do an open and med procedure and subside the amount of pain, that's something that could wait or could be managed by that. So whenever I see the case selection, I always look at the x-ray, say what cases are to be done, or some of the general dentists asking me, should I do this root canal treatment? I always tell them, if you feel comfortable of doing something, you should do it absolutely. What do I look into the x-ray, which is the first thing that we usually look at when we see a patient? I always look at the anatomy. I always ask for 3 different angled periapical, mesial shot, straight shot, distal, along with a bite wing. Bite wing allows me to see the bone level and whatever is in the chamber, and if there is any decay, interproximal areas, we can see it better. And PAs in 3 different angles can show me the complexity of the anatomy within the root canal system. Is it calcified? Is it semi-calcified? Is there any pulp stone? Do I see the canals vividly? Is it entering other anatomies possibly, like some of the upper maxillary molars? Some of them could be pushing through the maxillary sinus. Then in that case, if we doubt, we have to do the CBCT. I look at all those factors before running all my diagnostic testing. So the first thing I do is the radiographic evaluation, basically. So yes, so basically when those topics come along, then we go to diagnosis, basically. First thing I always ask the patient is about their medical background to just make sure that we are not harming the patient, which I'm sure you guys know all of them, so I'm not going to even touch on any of those topics. Then it goes to diagnosis. Diagnosis is the most important backbone of endodontics. Randomly, I see some general dentists, unfortunately, making a diagnosis only by looking at a radiograph. That is not a complete diagnosis at all, because it's a two-dimensional entity. We don't understand the depth of the caries. We don't understand so many things. The minimum things that should be done for any potential candidate patients for root canal treatments are as follows. The first thing that I do, I always look inside all the anatomy to see if I see any abnormality. Do I see any sinus tract? Do I see any swellings? Do I see any malocclusion? Do I see any sign of grinding? Do I see bruxism? All those things. Then what I do, I go and look around and ask the patient, what is bothering you at this moment? Is it, and usually one of the following response come. When I drink cold, it bothers me. I think whatever touches my mouth. Or some say, we don't have much of pain. It's something vague, comes and goes. And they cannot point at it correctly. They say, oh, sometimes it's here, sometimes it radiates around. So I start doing my biting test first. Biting test should be done with a tooth sleuth. You cannot just have them bite on anything. You should cover every single cusp. The reason, because one of the major sources of pain that an endodontic patient end up being on my chair is a fracture cusp, which basically enamel has been cracked and now dentinal tubules are exposed to saliva and so many other irritants, and patients keeps feeling sensitive towards biting, cold, and so many other things. So biting tests should be done very, very accurately. Then we do the percussion test. We could use the end of our mouth mirror or so many other things that we are basically using for that. And I always use control teeth. I use 3-4 different control teeth. Only tapping on a tooth that is suspected, or only doing the vitality test or any test only on the suspected tooth, cannot give you a very crystal clear, basically. My apologies to everyone. I don't know what happened, but I don't know up to what point you guys heard me. So I'm going to touch on diagnosis again, basically. So I covered the bite test that I said I always do the tooth sleuth. I cover every single cusp to make sure there is no cuspal fracture and make sure that I'm doing it accurately rather than just putting a big cotton and have the patient bite on it. That's not an exact test. Then I go to my vitality test or cold test, and I explain to patients how to respond to that. Endo ice test cannot be done just by spraying air on a tooth, cannot be done by a cold carpule that you had in your refrigerator. It got to do with endo ice and cotton roll, because you have to touch only certain surfaces of the tooth and make sure everything else is dry around. And again, as I explained, I use 3-4 control teeth minimum, and I usually go for the contralateral arch or opposite side, so it's not close to the side that is patient is being bothered. What I explain to patient, I always tell them I'm going to apply something cold to your tooth. As soon as you have any sensation, the reason I use word sensation, because some of them say, oh, it just felt cold, I didn't have pain. That's still a sensation. As soon as you have any sensation, raise your left arm in a way that I can see and drop the arms when that sensation is completely gone. So if it's wearing off, it still counts because there is respond to that agitation, basically. So I do 3-4 of those. I look for basically lingering pain to see if I can diagnose any irreversible pulpitis, which I expect in the tooth that either had recently crown down on them or any kind of restoration, or the ones that have deeper decay. And of course, if I don't see any response at all, it means the decay has been too deep and already killed the nerve. Basically, we are in a necrotic stage. Or if the crown has been done, basically some general dentists, they like to turn the water off. They literally cook the tooth. So the nerve is dead. Again, we are in a necrotic stage. Or the third reason could be trauma, which I don't want to get into it. I'm talking about normal circumstances. So bite test, percussion test, and vitality test. And I do electrical pulp test, because in conjunction with electrical pulp test and the cold test, you can pinpoint which tooth exactly is either having irreversible pulpitis or is necrotic. But I know most general dentist folks don't use that at all. Then I look for perioprobings And usually when we are probing, we do bone sounding. So I always advise the patient, if it feels sensitive, let me know. I can number on your gum, because bone sounding, you really want to go deep down to touch the bone. We are basically supposed to measure the distance from where bone end all the ways to CEJ to look to see if it's more than 5-6 millimeter, which could be indications of a crack or vertical root fracture, or things that us endodontists will look for. Usually they're in one isolated area. And again, if I see a patient is Broxer with a more prominent, smaller jaw, missing a couple of posterior molars, which basically lack of posterior support, those are the times I start thinking about that route. And the patient says, you know what, I have this pain that when I bite is exaggerated. So usually on rebound bite, you see those kind of pains. So that's the diagnosis. And along with that, the perfect medical history of the patient, radiographic evaluation, all those, if I can come to a definite diagnosis, I tell the patient whether I recommend root canal treatment or I don't. Or in the third option, some of them, when we suspect root canal fracture, vertical root fracture, I tell the patient, depends how advanced the fracture is. So I got to get into the tooth. If it's something that has passed the margins and is inside the pulpal floor, then we start talking about prognosis to the patient, that what to expect out of this teeth. And that's another topic that comes along, because I had a very interesting conversation with Dr. Prasad, that he asked me which cases that there are perio and endo involved, you decide to do the root canal treatment versus implant dentistry. That's a fantastic question, and that's a topic that comes along in so many general dentist offices. Usually my response is, it depends to several factors and elements. The first one, the philosophy of the dentist who is treating, the philosophy of the patient who's been vividly educated about his or her options of treatment, and at the end, financial aspect. That's one reality in life. So prognosis is something, as you guys know, we categorize it to good, fair, guarded, or poor. Depending where we are standing of this prognosis, we can tell to patients what are the options. For instance, if a tooth comes that I see it has a vertical root fracture, but tooth still shows the signs of vitality, it means the bacterial load has not been as advanced. This is a more recent crack. The periodontal pocketing is not as deep, and the fracture is only on tooth margin. I always recommend to patients that this tooth has a much better chance of success if you get a very good root canal treatment, following with a full coverage crown that can support so this crack does not progress to more advanced stages, and you get a chance to use your tooth for several years. But patients usually ask you, how many years can I use this tooth? There is no definite answer to any of these. There are studies done that I'm going to quote a few for you that talks about the prognosis of a tooth. In 2004, Saleh Rabi and Rothstein, which both of them are my mentors, my faculty, Dr. Rothstein is the chair of program at USC, they conducted a very nice and long-term 8-year research, and they looked at 1,400,000 some plus teeth, and that's the outcome they came up with. On initial treatment, there is 97% successful outcome if an endodontist performs a root canal treatment, and 96% of those teeth after 8 years, they had no additional intervention. It means they stayed intact in the tooth and very much functional. There are other studies that looks about prognosis. So the Chevingi, after 5 to 10 years, they looked at teeth and they found out 88% of endo-treated tooth were basically radiographically they were healed. So if there was any lesion seen, 88% of those, the lesion went away. But more interestingly, 94% of those teeth, they were clinically functional. When I say clinically functional, it means after 5 to 10 years, when a radiograph was taken, there was some sign of periapical radiolucency or something that we usually detect on that. But the size of that lesion either got smaller, or we could relate it to something that is called scar tissue that we all know, that it could always show that. But if somebody wants to really know what's going on, they got to biopsy the tooth, which in that case, you lose the tooth. Or they got to go through periapical surgery like apicoectomy, which in the cases that we don't see any sign and symptom or discomfort in patients, sometimes we don't recommend that. We discuss it with the patient. We still do see this one, but let's keep it under observation. We see the patient every 6 months for cleaning in our office. So we put a note every 6 months, let's do a radiograph. Let's see if we see any changes of lesion, any unusual sign or symptoms. Another factor that kicks in, I'm going to give you another code.
Setzer basically looked at the teeth that if they have pre-treatment condition that could affect the outcome of root canal treatment. By pre-treatment conditions, I'm going to touch base on two most important elements. One of them is clinical attachment loss, which is the bone loss, obviously. And the other one could be the apical periodontitis. Both of those have a negative impact on the outcome of the treatment, regardless. Periodontium is what is supporting the tooth. Even sometimes if we do the best root canal treatment in the world, if the cause of the attachment loss is perio-related, that needs to be taken care of by a periodontist to see if they can do it or not. But if it's an endo-related bone loss, root canal treatment will definitely take care of that. For some instances, we see some bone loss and we see sinus tract on a patient without any vertical root fracture. If you treat such a tooth, usually molars, such a tooth, even anteriors and premolars too, but mostly I see the molars. If you treat this tooth properly, by proper treatment, this is one of the cases that I do not do it in one session, even though there are literature who support that you can do even a necrotic tissue with sinus tract in one session. I personally myself like to do these kind of cases in two sessions. I open up a tube, I find every single canal, I make sure I got patency, and I give it a very, very good shape. I'm an 06 type of taper endodontist. Literature shows there is no difference. Actually, there is one funny thing our director, Dr. Ross, usually told us, says as long as you can get your irrigant to the apical third of the root to make sure you have enough disinfecting, he doesn't care whether you do it 02, 04, 06. But 06, I like the shape better, and I feel personally more confident that I got my irrigant to the apical third, which the most of the game of the endodontist starts basically. So if there is a sinus tract related to that bone loss, when you clean, I place calcium between 4 to 6 weeks. I have the patient come back. That way, I made sure that the bacterial load inside the canal and root canal system is lower. And then when the patient comes, we see sign of sinus tract is gone. You even see some sort of healing in that pocket when you remeasure, because you took the source of agitation away so that pocket could be resolved. So that's an endo-related case. And that's why some of those cases that we are not sure, we got to do it in 2 sessions. Take everything out, place your calcium after shaping and irrigants, of course, and see the patient between 4 to 6 weeks. And if you see sign of healing and there is no crack, then finish the root canal. Those things, it goes away. But if the source of attachment loss is perio for any reason, that got to be addressed in conjunction with perio. But we usually take care of the endo first, and then we seek out help from our periodontist counterpart. There are other studies that has been done on outcome of a tooth with pre-existing conditions. Another one is done with the Chevinge, which says teeth with normal periapices preoperatively had 93% chance of healing and 97% chance of functionality, basically. In a matter of 5 to 10 years, again, they're looking at it. And teeth with preoperative conditions or apical periodontitis, they showed 82% radiographic healing and 94% were clinically functional. Again, folks, let's look realistically. These are very, very high outcomes. If somebody comes, because usually the patient asks me, what would you do if it was your own teeth? I tell them if it was my teeth, if I had odds 8 out of 10 it works, I would take that chances. Even if I go to Vegas, if somebody tells me, if you place your bet on a bet that 8 out of 10 you win, that's one hell of a bet, in my opinion. I don't like to compare teeth with betting, but in reality, we're talking about odds. And these are the percentages that has been extracted out of long-term research that has been done from my colleagues or my mentors, basically. So yes, in cases like that, we got to see where the patient comes from. And at the same time, we got to see where the general practitioner is coming from. Remember, specialists are not the one who write the treatment plan. General dentists folks are the one who come up with the treatment plan because they do complete oral examination and they decide which route is the best to fit the patient's needs, finances, timings, and all those issues. Yes, thank God for implant dentistry in times that we cannot save teeth. Thank God that implant exists. But let's be realistic. Can we put our money down on every single implant that is placed in some patient's mouth? Do you think that has 100% chance of success? I doubt it. Any dentist who knows the slightest about outcomes of root canal treatment and implant, they know none of them are 100%. Nothing in life, as a matter of fact, is 100%. That's usually when I talk to patients again. They ask me, how long would this last? I always tell them there are two things in life that their 100% outcome could be seen. In field of dentistry, extraction, of course, 100% you extract the tooth. The other one is death. 100% it will happen to all of us. Nothing in field of medicine or dentistry has 100% outcome. And if somebody claims that, they either trying to win that battle in that conversation or they just don't know any better. So 80 above percentage chance of success that I'm mentioning in all of these, and some of them they go as high as 92.37%. Those are really good odds. Tooth should be safe. But again, if a patient comes to you says, you know what, I don't like to take my odds. I don't like to take my chances. I want something to be more sure. I definitely recommend extraction because I cannot guarantee that for them. And that's what they're asking me. If a dentist wants to sometimes make their life easier and extract the tooth, I am not in a position to tell them you should not. I always advise them that there are these options if a patient likes to save the tooth. And at the end of the day, we can only do our best. There are times that general dentist goes in there, they cannot find center canals. They cannot get the patency out of the canal. Instrument gets separated, ledges get created, perforations do happen. All those things brings the prognosis lower. Remember, I'm talking about the cases that none of those obstacles are along the way, which we have the similar obstacles that could happen during implant dentistry. How many times we open up tooth, not me, I don't do implants, but I've seen other folks who do it, and they realize there are other things needs to be done before that because they did not do their planning properly. Because I know if a surgeon wants to do a very good implant, they make sure they have their CBCT on. They analyze everything from different directions, different aspects. They make sure if the patient needs a sinus lift, bone graft, or other things, they walk patient through it. But unfortunately, I've seen some careless treatment too, that they opened up to started placing implants, and the outcome is very questionable. We don't know what's going to happen, really. So these are the diagnostic things that I do, and I talk to patient for a good 15, 20 minutes when this scenario comes up. Some of the cases is very straightforward. Yes, there is a decay, and you see it in the radiograph, you do your testing, you come to conclusion very quickly. You need this treatment, and these are the outcomes. Some of them not as easy as we can just call it. Sometimes when we cannot even diagnose the tooth very clearly and patient does not have that severe pain, I have them come back in 2 weeks. Let's reevaluate again. Let's look at things differently. Let's do a CBCT. Even if there is no CBCT at the office, let's refer them out, have them send us the disc or CD or whatever they have, open it up. Let's gain more information. Remember, sometimes we only see a periapical radiolucency in a two-dimensional radiograph. When you see a CT, the size of that lesion makes all of your treatment planning differently. Like if I see a lesion that goes more than 5 millimeters, that it just showed me some radiolucency in the apical lesion, but in reality, I see it's a much more thing. I always tell the patient, I'm going to go ahead and finish the root canal, but if the lesion does not heal within a certain amount of time, you might be up for an apicoectomy, which I need to get in there surgically with raising a very simple flap, a small opening, and cut down the last 3 millimeters of your root, which usually the reason we do last 3 millimeters because all the other branches of roots, the lateral basically branches, are out to be in the last 3 millimeters. Those are the ones that usually cannot cover, or some of them gets missed. Because another thing I'll tell the patients, do not have the imagination that inside the canal is like a long tube. No, in reality, it's like a spider web. We find the main routes and we give it a certain shape, and with our irrigant materials, which is sodium hypochlorite, which is the best, EDTA, and in some cases MTAD, when we are hoping, our hope is that we are reaching down in all those spider webs to kill the bacteria that has been housed, depending to whatever the diagnosis was, and subside that level. Nobody can make that area sterile. Actually, research again shows that we are trying to bring the bacterial load from the 10 to the power of 10 all the way down to the 10 to the power of 2. And by doing a very good apical sealing in a warm vertical compaction technique that most endodontists do these days, we are pressing our sealer and our gutta percha, which is semi-warm, into the tubules and into all those lateral branches, so it houses and present all those 10 to the power of 2 left of bacteria in there, so hopefully they die. That's why it's not 100% thing. Worse the prognosis or later the prognosis is done, lesser the outcome. It's always better, and tooth is more forgiving if you do perform a root canal treatment on an irreversible pulpitis case, that started giving symptom to patients within the last month rather than somebody who walks into your office with a sinus tract. Sinus tract means the bacteria had time to sit in there to regrow and expand and make so many more damages and penetrates more deeper into the lateral canals and all those beautiful anatomy that we have inside the tooth. So again, patient's education and setting up expectations, it's the key. But for that, whoever the operator is, either it's me or a general dentist or some of my colleagues, we must do a great job of diagnosis. If diagnosis is not done properly, it's not worth it. It doesn't do any good to the patient. Case of emergency. Emergency is a different thing. In my opinion, what an endodontist does, we can categorize to 4 different procedures. Either initial treatment, either a retreatment, either it's an emergency with patient comes with severe pain, something that's just unbearable that we got to look what is it. Some of them could be trauma. Kids with a false tooth, things like that, who walk into your office. Not too many, but it's 10% of our work. And the 4th category is when more dentistry needs to be done. Dentist wants to make sure that nothing blows out later. I have so many of these cases. Patient is getting a new crown and she or he had a previous endodontic treatment. There is no sign of discomfort. They send the patients for evaluation to me to basically have my word on the treatment plan to tell them it's okay, nothing is going to happen. I do all my testing. There is no sign, there is no symptoms. Then I have to radiographically evaluate. What I look for, if all the canals has been covered, if the MB2 has been found, if the filling has been done properly, you see it's very condensed, there are no voids. If they went all the way to the end of the apex, they're not short, they're not long, they have not extruded, and they have not missed anything basically. So those are the things that I look for. If I see any kind of shortcomings that appears to me, I always talk to patients, said, listen, you do not have any sign and symptoms. If it's done properly, I tell them, you know what, don't worry about it. In my opinion, it looks good. Go ahead and get your crown. And if something happens in the future, I can always go through your crown and redo the root canal. But let's not jump the gun. Wait on it. Save your money. Have your money in your pocket. And who likes to have a root canal treatment? Nobody, obviously. So, but in the cases that somebody comes, their restoration were off for, let's say, 2 months. Saliva has been exposing that root canal treatment. Even though if patient doesn't have any sign or symptoms of discomfort, I cannot guarantee that the root canal system had not be contaminated. We all know the source of bacteria is within our saliva. As long as they stay inside our mouth, we coexist just fine. They help us through digestion, speech, and so on and so forth. But once they get inside the tooth to the root canal system, they start acting totally different. So if I see a tooth has been exposed to saliva for a long time, my recommendation is retreat. If I see there is a shortcoming in the filling, in the shape, in the way that they filled up or obturated the tooth, so many other things, again, my recommendation would be a retreat, because I cannot guarantee somebody else's work that I don't know. But what I do, I can guarantee it. Not guarantee it, I can put those percentages that I mentioned on it. So these are the 4 cases that walks into our office. But if an emergency comes and you do not have an access to an endodontist and you want to help the patient yourself, do a proper diagnosis again. Make sure it's an odontogenic pain. We have non-odontogenic pain, which is not related to root canal. Patient is swollen because of other reason, not because of a root canal. It's an impacted wisdom teeth that is bothering them. It's a neurological problem that patient has. So many other things that we need to be distinguished throughout our correct way of diagnosis. And if we cannot really diagnose, refer them to the closest endodontist that you have. Or if you have an endodontist employed by your office, if you can manage the patient by medication, put them on Tylenol 3 and ibuprofen, in some cases Norco. I see overuses of amoxicillin. Not every single tooth pain needs to be given amoxicillin. If you see sign of infection, which is usually related with swelling, fever, redness, or pre-existing conditions that patient might have, yes, put them on antibiotic, but not every single tooth that comes to you and patient is in pain requires any kind of antibiotic treatment, which most of us are love to prescribe amoxicillin. And we all know the danger of superbacteria. If we keep doing that, basically we are making everybody resistant towards the bacteria's presence to our field. So I stay shy of giving antibiotic unless it's needed. Yes, if I see I went to a treatment and the infection load was very high, or the periapical lesion was bigger, or patient had flared up, which happens. It's my job to talk to patient that if a tooth is necrotic, yes, sometimes during treatment, when you're cleaning things, some bacteria, they go outside of the root and cause certain symptoms such as swallowing. So that's normal. In those kind of cases, I make sure my patient is equipped with the right prescriptions, and I educate them. If you see any signs of fever or swallowing, start your amoxicillin or whatever choice of antibiotic that I gave them. Otherwise, after 90% of my treatment, all patient gets is ibuprofen, 800 milligram, and that should take care of it. And I always tell them, it's like when you go to gym the day after you feel sore. So it's right, I took all the nerve and blood supply out, but the surrounding tissue, the bone and gum and everything else, they still very much so are vital and have innervations, and they get inflamed. Nature of our job causes inflammation. For that, ibuprofen is the best friend that anybody can ask. Again, let's touch back on what offices, in my opinion, could use an endodontist. Most of the times when Synergy introduced me to new office, I get in touch with the general dentist because I love to know my colleagues. I always learn a great deal from the general dentist that I work with through their great work in restorations, through patients management, office management. It's just educational. Wherever I go, I appreciate the points that I learned from the general dentist. And I always understand I am their guest at their office. That's their office. I don't just jump the gun and tell patients somebody was right or wrong. I make sure I know enough of the history and what has been told to the patient. It's my job to be honest with patient, and I am. But there's this saying in my native tongue, I try to translate it. They're saying there are 3 ways to tell a person sit down. It's like, please sit down, or sit, or in a more harsh language to ask somebody to sit. So same thing with breaking good or bad news to somebody. If I see something is not mentioned to the patient, or is different, mentioned differently to the patient by the general dentist, I always get a hold of my dentist first and tell them, hey, listen, this is what I see and this is what I think. And I'm going to inform the patient. If they are in, I usually ask them to step into the room with me so patient doesn't think that one person said something, the other said another, what's going on, because that creates a little bit of dilemma in certain offices. I always make sure that patient is taken care of. That's our job. That's our main goal. Second of all, I always stay in touch with all of my general dentists and their staffs. I always ask them to show me the periapical radiograph or bite wings a week before I step into the office. I always ask for the full medical history to look at, see if patient needs to get any kind of medical release before I see them, because these are the things that kills the time when I go. If they book the patient for an hour on my chair and I come and they tell me, yes, by the way, I had a stent in my heart 3 weeks ago and I'm 3 different kinds of blood thinners. We are not physicians. I am not, at least. And I never want to jeopardize patient and my license for any kind of liabilities. I always make sure I have all my sides covered. I always seek out for medical release form from their physicians. I don't act to play like a physician, and I'm not. So, but there are rarely cases that I send them out. Normal things, we know what to do. But if some cases that we are not sure, we don't have backbone of knowledge that comes from the medical field, I always seek out help from physicians, whoever is treating physician. I send the medical release, doctor, so on and so forth. I have your patients on my chair. This is what I'm going to use. That's how long it's going to take. This is the medication, and that's the procedure. Please advise accordingly. If I need to adjust any medication, stop them or not stop them, or pre-medicate them or not pre-medicate them, all those things. So that's the second thing. I am always in touch with offices. A few of the offices that I go in Northern California, in Turlock and Modesto area, they are equipped with CBCT. They're fantastic general dentists working there. And whatever they do, they connected me to their CT machine. So as soon as they're scanning the patient, I look at the scan from my laptop here, and I can give them way more better inputs. And that helps them whether they should go towards implant dentistry or they should see me to try to save their tooth. And that way, patient's time does not get wasted either. The other one is basically, again, the philosophy of the general dentist. Some general dentists, they are more comfortable with implant dentistry, and that's part of their business. I cannot argue with them much. That's their choice. I cannot tell somebody, why did you choose doing this or not? It's not my place. If they ask me, what do I recommend? if I am always for saving teeth. I am a saving teeth doctor. So I always go towards the direction to accommodate the patients to save their dentition, because my true belief is nothing can be a good replacement as good as your natural teeth, as long as we can keep it. So in between some of the mistakes that I see that happens in some of the general dentist offices, most of the office owners are very cautious. Usually comes down to the associates that they bring in, because they like, most of them, younger associates, such as so many of my students who are entering the world. They are eager, they are knowledgeable, they're smart, and they're more daring than us. Experience makes all of us more humble. You have to run into a few difficulties until you appreciate conservative dentistry or pushing your limits. I'm all for pushing your limits and improvements, but in a very, very calculated pace. You cannot just start doing something if you do not have knowledge. So the problems that I see has been happening in so many of the dental offices, that the associates of them, they get themselves into cases that they either don't know when to stop or how to finish it. They go to calcified pulp champers that, under their usually not very strong loops, or if they have any, they cannot even see the distinction between the dentine and the pulp stone, and they don't know how to remove it. So they grab their longest burr that they have and they start pinpointing. So forcation perforations, which is one of the most common perforations repair that I have to do, happens to usually lower molars, because in most of the cases, number, let's say 30, number 19, dentists looking for those canals. They are grinding all around, and before they know, they are out there. And as soon as they see bleeding, they think it's a canal. They put the file to inside the canal. If they have apex locator, they attach it, and all of us know what they hear, that continuous beeping sound 5 millimeters down the canal. You have perforated for sure. You're out of the canal. There is no way that after 5 millimeters you see an apex, unless it's a huge resorption, which all of us dentists know that is not very common. The other problem that I see happens to so many dentists who are not as experienced, they separate instruments, because first of all, they're not as equipped as we are. I have so many different systems, and they mix and match. I don't finish one tooth with one system necessarily. Depending to the need of the canal size or apical gauging that I fill with my hand files, I go towards different systems. So we have the luxury of having all these equipments around us, because that's what we do mostly. And it's not cost beneficial to so many dentists to buy all these things, because the reality is they might do 3-4 root canals per week. I do 10 of them per day. So for me, it's justifiable to buy all these things. First of all, I know how to use them. Second of all, I know where to use them, and I get a chance to use them. If I buy them, I don't just pile them up in a closet that until one case comes along. So yes, some of the canals that are a little bit have more curvature anatomy, they have more calcification anatomy, or simply general dentist could not locate that MB2. Most of the cases that patients have a root canal and they end up coming with pain, it's a missed MB2. It's a vital case. Still there is tissue left and patient feels it. Or some of the cases that you see, they done a beautiful, decent job on an upper molar, but there is lesion on mesiobuccal root. If the office has CT, I immediately take a CT. I look for MB2. If not, I get into it. Most of the time, I'm successful enough to find the MB2 without CT. Don't get me wrong. I love using microscope and CT, but majority of the places I go, they do not have those. But I'm equipped with 6.5 magnification, and practice makes perfect. My daily job is to look for those kind of anatomies that not necessarily general dentist deals with it as much as I do. So automatically, I think we can find it a little bit easier and better. The third topic is, so many of the office owners, they start looking at their time management and the worth of their chair time. If an office has 6 and above number of chairs, if they have minimum 6-7 cases, it is beneficial to them to bring in someone like me, free their chair time, be able to charge a little more because it's a specialist cost, and to be sure that they do not have to deal with the liability of this root canal treatment. And obviously, literature shows that a specialist can do a little bit better job rather than the numbers that the general dentist shows. So that office automatically, they guaranteed better service to their patients. More production comes to the office. They free themselves of that annoying root canal that sometimes keeps their head busy when they go home. What happened to that patient? That patient could call them at night, say, hey, I'm still in pain. And at the same time, when they're free, successful general dentists, we all know, they're always booked. They go do another crown. They go do another filling. They go do another beautiful smile design. They go do the things that they are master on. Believe me, when the patients come and ask me about the restoration, when it comes to aesthetic zone or anything, I tell them, hey, listen, I used to be a general dentist, not very good one. That's why I went after specialty. And believe me, you don't want me to have opinion about the restorations. I am not really good at that. That's what the general dentist is master at. So I leave that conversation between you and your dentist, that what choice of restoration fits you the best and what could be done for you could not be done for you. My job is to take care of your root canal treatment, and I'll do it to the best. Usually I tell patients I'm the plumber of dentists. I'm going to go inside the canals, make sure they're clean and disinfected, patch them up, make you ready for your dentist. I put things in normal terms so they understand better. The offices that we work together, basically, the ones that we have longer term relationship, is working out for both sides beautifully. For all three sides, actually. Office, better production, better services, less headache, freeing their dental chair. For me, I'm guaranteed a very good day that I go to the office. I do what I love to do. I love to do root canal treatments. For me, I'm very blessed and thankful to my director that allowed me to be in this field and really enjoy my work. Since I become a specialist, I am a much happier person because I was not a very good general dentist like you folks. So, but I'm a very decent endodontist, so I enjoy my work. At the same time, they guarantee that I come for the distances that I go. I get financially compensated well. And at the same time, they support me with fantastic instrumentation, with fantastic assistant chair sides, with fantastic front desk communication. Those are the models that we are very much successful. And some of the models that I go, no, there are less volume. They're closer to where I live. So my expectation is lower too. I go do 5-6 root canal for them and we come back home. The speed of endodontists are different. It doesn't mean who's better, who's worst. Some endodontists, they don't like to do more. It's not like they cannot do more. Of course they can. All of us, if you have proper education background, which most of us do, which if they come from CODA approved programs, we know enough to do root canal treatment. Some people, they don't like to push themselves, but they don't like to stress themselves. So they do 4 root canals per day or 6 root canals. Some of them do 6 to 8. Some of them, like me, I like to do more. I usually overlap rooms. In the busier clinics that I go, I have 3 assistants and 3 rooms. One room goes only for consultations or post-op meetings. The other 2 are the treatment rooms, which are fully equipped with my rotary machinery, with my obturations, with my ultrasonic, with all the toys that I need to play with 1 assistant in each room. So each hour I see 1 patient and I'm overlapping. So if the first patient sits at 8, the second one comes at 8:30. When I step out for cone fit radiograph, I'll numb the second patient, which I consulted before. I don't do same day consultation unless they're in pain, which I do open a med and get them off the pain and see them in the next session. Yes, I have fantastic support. The support that I get from Synergy is outstanding. And they are the one who do all the credentialing with the help of the office. They are the one who walk the offices through codings, scheduling, and they go through creating the contracts that protect both sides. They are the one who basically bring the foundation. I'm the last resort that comes. I come and do the job, basically. And yes, I do have fantastic support from the offices that I work with. In most of the offices that we work in a more long-term relationship, the assistance that they provide for me, we work in a way that we don't talk much. It's like a dance. The first few times it takes a little time, learn how to sync with each other. I educate them. I tell them what I need. I show them the tray design that I need. I tell them my time matter. Like it takes me that much to do the access. This is the amount of carpules I need preloaded with my sodium, with my EDTA. And after a few months, it's such a beautiful dance that me and my assistant, we don't talk much. They know that when Dr. Sirjani is done with certain instrument irrigation, that's the next step. They have the instruments ready. So that way we look way more professional in front of patients. Often looks very good in front of the patient because they usually advertise around us that we are bringing the specialist. It's better for the patient didn't leave. When I come, they get impressed that how things are done in such a silent manner without experiencing any kind of pain or discomfort. Because as we know, that's the number one anxiety reason for patients who want to get root canal treatment, pain. They think, is it going to hurt? And by the time I give them the first IA, they're not going to feel anything else. And I make sure they're fully numb. I test 2-3 times before I get into any tooth, make sure they're numb enough. Because if the patient feels the slightest things, you lost the battle, even if you do best root canal in the world. So my patients, they're always, always, always fully numb. I make sure they're numb. You do not want your patient to feel pain under root canal treatment. Believe me, that's the worst thing. And yes, I do rubber dam. I use rubber dam treatment in any single tooth that I do. If a tooth has been done a root canal treatment without a rubber dam, is under the standard of care. It's basically going to an operating room without having a sterilization all over, and it just doesn't make sense. If a tooth cannot receive a rubber dam for any reason, too much tooth structure loss, that's not a tooth to be receiving endodontic treatment. Of course, some of them we save them. We're doing crown lengthening first. So some structure is out there, so we can place the rubber dam on and later on do the post and core and crown restoration. Some of them we place the rubber dam over the gum. We get it sealed somehow because we know the general dentist is working on it right away after. The offices that we have better relationship and they don't care about the production of the post and core, who does it, they usually ask me to do the post and core for them, and I think that's the best method of finishing a root canal. That's the best coronal sealing that anybody can ask for. In the offices that do not have that space for them, and some of them they don't want me to do that, what I do, I always cover the top of my orifices with flowable composite, so in case if that cavity fell off or that temporary filling for some reason stayed there a little longer, at least my root canal treatment is not contaminated and it's being protected. It's my job to do a great apical sealing and coronal sealing and keep the patients and tooth protected until that root canal treatment is done. So again, the reason I gave you all this explanation and gave you guys a headache by now is to understand that not every single general dentist office has the potential of having a root canal specialist or any specialist in them. They need to look at their data first. You always ask them to take the last 3 to 6 months of data out to see how many cases of root canal treatment has been done. Look at the x-ray, what type of cases it was, and look to see how many cases has been referred out. Again, let's look to see for what reason it was referred out. If those two numbers are so low, then look at your number of extractions. How many teeth are you extracting? Maybe the office is set in a way that your associate is not feeling comfortable doing root canal. They keep doing extraction on the teeth that should not be extracted to begin with. And then we have to talk about the philosophy behind the office, that where you guys are come from. And if you are trying to save the tooth, then yes, if you have the numbers, by all means, someone like me could be employed by your office to improve the game, give better service to the patient, and be financially suitable and beneficial to your office. I hope that I gave you some useful information. If there is any question about how root canal treatment should be done, if you have any more technical question, I'll be at your service. And if there's any other question, I'll be more than happy to entertain to the best of my capability.
Thank you very much, Dr. Sirjani. It was just a fabulous presentation. You said you passed on all the tips.
Thank you.
I would consider as a practical tips, as a GP, what is that we could do, as a GP, what is that we cannot do. That is
all of us have limitations.
Thank
it's
you.
Not just GP. Even there are certain cases that we cannot help the patient, but we have to do our best to give the best service to the patient. That's the ultimate goal.
Absolutely right. And we do have some questions. And before we open up for question and answers, Darius, are you ready, friend?
Hi, everybody.
Great.
Hello.
Okay.
Hi, everybody. For those of you that don't know me, I'm Darius Somakian from Synergy Specialists. We're the agency that represents traveling dental specialists across California and nationally. Essentially, we're the middleman that comes to help pair you up with a pre-screened specialist. How does it all work? Well, generally speaking, the endodontist will bring virtually everything small equipment-wise, including a rotary handpiece, sometimes two, depending on the benchmark of scheduling. Specialty instruments. If the endodontist uses a scope, they'll bring the optics for the scope, and sometimes the practice will supply the counterweight stand for it. Supplies such as like gutta-percha points, paper points, the sundries as we call them, those are typically supplied by the practice. The main considerable cost in that is the rotary files, as most may know. And typically the compensation works where it's arranged on a 50-50 based on the adjusted production or the greater of a per diem that we agree upon. A per diem is not so much a production goal, it's just more as a booking fee for the specialist's time. Our recommendation when we set up matches for endodontists is to only credential Delta if you can, I know there's a lot of offices that are heavy on PPO insurances out there, but we've noticed that the most productive route for all parties really is to build in-network with Delta, where you can get 1250 a molar or so, and line up a pretty consistent schedule that way. Typical average productions, you're looking at endodontists doing anywhere from, as Dr. Sirjani was saying, 6 cases upwards to some even like, in the double-digit case range, which Dr. Sirjani does himself. There's a lot of benefits to bringing an in-house endodontist. I just wanted to point out that, number one, you're having the cases being treated by a board-certified or eligible endodontist. That leads to, number two, reducing the liability of having an expert handle the case. And third, our recommendation is to just credential the endodontist with Delta and then work it where you're out of network on the rest of the plans. The fourth benefit I just wanted to point out is, in my opinion, your patients are probably going to want to get treated for a root canal in the familiarity of a setting of a GP practice that they've been going to. I'm just speaking from a patient standpoint on that one. And after we introduce the endodontist, we help train your office together with the endodontist's participation to some level. Synergy gets involved to teach you guys how to do the billing, consent forms, scheduling tips, strategies. We have a whole 1 hour dedicated training that we go through, which I'll share my screen with you just to give you an idea. It's a presentation that we put together one-on-one with your office manager that's going to go through an overview of facility preparedness, equipment, who's responsible for bringing what, the supplies, health history review. It's pretty elaborate, the amount of detail that we'll go into to make sure that this match is set up properly for you guys. And one of the next steps, if you're interested in contacting us to get matched up with an endodontist, would be to schedule a time to speak with us. You can call me anytime. Here's our website and our contact information. I just posted it on the chat with everybody. After the meeting, I'll also send over a transcription of the wonderful presentation that Dr. Sirjani did. Thank you very much for that, by the way, along with the PowerPoint presentation that we use for training our offices. We'd like to share this knowledge with you guys and be able to just empower you to start developing a multidisciplinary type of approach. Thank you so much for the IDA for allowing us to come in and help put this all together. We really enjoyed working with you guys. Thank you.
Darius, thank you very much. Yeah, certainly we need you for our association. Okay, doctors, time for question and answers. Dr. Sirjani, yes, I do have a few questions. The first question is, some doctors do build up and crown preparation on the same day root canal is finished. What is your take on it?
Answering to that question, I am a huge fan of doing the post and build up the same day because of getting a perfect coronal sealing. So yes, if any office that they can see the patient right after me, I don't even take the rubber dam off. I send the patient general dentist to keep the isolation, and I even fabricate the post space for them so they can go ahead and do it right away. There are a few things as far as business aspect. Remember, some of the offices, they want me to create the post space because they can charge the patient towards the endodontic treatment for post space fabrication. Most insurances do not allow you to create the post space fabrication and place the post and core in the same day. They only pay for one procedure. But if you have the patient come back the following day, you could charge for that along with charging for post and buildup. From scientific perspective, it's the best to get the post and core ASAP, right after root canal treatment. From the business perspective, sometimes it plays a different role. So that's one thing I see in some offices. But from the endodontic perspective, I would love it if myself or somebody else can place the post and core right away.
That is the case, doctor. Would you run your technique as to how you do the post space? What is that you do, and what kind of post do you place? We can run in detail the entire procedure.
Sure. Because of limitation, I cannot mention name of products, but I'm going to tell you what I do usually. If I'm fabricating a post space only and I'm not placing the post myself, I always ask the dentist what they want, how long they want, because literature shows in reality I need to leave up to 5 millimeter of gutta percha left in the apical third. So we got to look at the crown to root ratio, which of course we look at all those before the treatment starts, because as you know, some of the anterior tooth, when you want to try to save them, they've been through rounds and rounds of treatment. They might have even had an apicoectomy before that. You got to look at the root to crown ratio if they want to place a post and stuff. Some of them are not a good candidate. So if those barriers are not on our side, what I do with my system B or touch and heat system, I go take out some gutta percha, or I don't fail to begin with. With the piezo reamer, I go and create according to the size that the dentist asked me to. I go create the space and I leave enough room for them to, and I ask them how many millimeter you want to do. Most of the ones that I do myself depends of either I am providing the post material or the office does. If I have both choices, I like to go with fiber post. It's much better than the metal post that we used to use. But let me tell you a perspective that I got from a prosthodontist. From the restorative perspective, which you guys are the master of it, I got the lecture from Dr. Simon, which is a very well-known prosthodontist in West LA. They are staying shy of using any kind of post at all. They are a big believer that post weakens the structures and increases the odds of any kind of fracture within the tooth. So the newer technique that they are using, I haven't done it myself, but I've seen how they work. They create the post space with the resin material. They go inside the post and they do a connected post and crown buildup only with resin without employing any kind of post. But in reality, honestly, I'm still placing post myself because I have not tried that technique or mastered it yet. But the way I do it, I do etch and bond inside the canal. Some of the folks don't do it. I do. I want to make sure everything is etched as much as possible, even though there are a few literature that shows that etching too long around the pulpal floor can basically denature the collagen that they have within the dentine and so forth. We could have weakening that structure restoratively. But I do it to the minimum of the dentine amount of time, which is 10 seconds. Then I come out, I dry, I place some of my dual bonding and the post and the core material. I come up. I do in incremental segments. I am a big believer in micro leakages that come after curing. So I start adding in a triangle manner to the sides first. Then I come into the center and fill up everything, make sure I'm free of any kind of voids. And the tooth that I do post and core, I always take them off occlusion because I don't want the patient go home and bite on something hard or causes a fracture because of occlusion before they receive their permanent restoration. So that's what I do.
Okay, you mentioned you're going to just use like a resin buildup. That's what you feel comfortable.
That I have not done it myself. I'm telling you what I learned from that lecture from the prosthodontist. Yes.
So what's your choice in terms of selecting the post? What would you use?
What kind of post? I use fiber post mostly.
Okay.
Yeah.
All right.
I do fiber post. The disadvantage with fiber post is if a tooth requires a retreat, it's most of the time it's very difficult for most dentists or endodontists to distinguish from where the fiber post is and from where the dentine is when they want to shave it down. Because if you have a metal post, you can, I can, or most of the endodontists can, take it out of the canal with ultrasonic tips. We basically insert vibrations in different areas until it loosens up and jumps out. That's how we take it out. But with fiber post, you cannot do such a thing. You got to drill down the canal to eliminate the fiber post. But I use Monspur, which are long shank, slow speed burrs, and I employ those in cases that I need to get rid of any kind of fiber post that was placed by someone else.
Okay, doc. And I have a question from a doctor here. How long after a RCT of upper molar the patient starts having symptoms when the MB2 is missed out completely?
It's a very loaded question. It could be right away. It depends to your diagnosis. It depends to the condition preoperatively. If a patient came to your office with a hot tooth, meaning that they were in severe pain, that's the first stage of pathology, which is the irreversible pulpitis. And assuming that the periapical lesion did not exist, patient was not sensitive to bite, they're mostly sensitive to thermal sensitivity. Patient could stay with pain until some body to body is different, until the bacterial load increases in a way to kills the remaining tissue. But in certain cases that the tooth has been diagnosed with necrotic tissue, that could take a little longer. And usually those kind of pains are associated with sensitivity to bite or percussion. And in the end stage, they lead to having a sinus tract, which is not associated with pain whatsoever. Patient usually complains from having this little bubble that comes and goes periodically. And we usually do sinus tract tracing. We place a 25 to 30/06 gutta percha size inside the sinus tract, and we take a radiograph. It takes you right to the where the infection is. So in cases of missed MB2, if they're not cleaned properly, which if it's missed, it means it has not been touched, depending to the pre-diagnosis and the stage of a tooth, you could see it from right away or all the way after 6-7 months that things can start showing up.
So again, what's your technique in terms of identifying MB2?
Well, first of all, experience. You got to know anatomy. You got to know where to look for things. And if with the assumption that you know the anatomy really well, I use ultrasonic and different kind of burrs that is designed for endodontists to trough the pulpal floor, to get rid of pulp stones, to get rid of calcification, to look for dentinal map. As you know it better than I do, I'm sure, in the pulp chamber, the floor of the chamber, when you clean them, you see a very, very thin blackish line that connects every single orifice together, which is called dentinal map. So us endodontists, with our magnifications, we rely on a lot of anatomy that we see to trace for things. And out of experience and having, as the gentleman who represents the CBCT mentioned, employing CBCT, you can see through the tooth. If there is an MB2, you see it, you measure that how much distally, mesially, buccally, lingually you need to move to look for it. In some of the cases, if you have the luxury of using CBCT, which I think is becoming the standard of care very soon in endodontics, you can see that if the first of the is, let's say, is calcified, if you drill down to 3 millimeter down, you will get to the point that you can achieve patency. In that area, you'll have way more confidence to drill down with, of course, specialized instruments to get through the calcification in the first coronal third of the root until you get patency and find the rest of it. But if you do not have CBCT, basically you have to rely on your tactile sense and your visibility and your experience to locate them. There is no other way. You got to know where to look for it, because some of the tooth that I see that it was initiated by a general dentist, when they come, the way they did their access, they were looking at the tooth in the wrong place. In cases of upper molars, like first molar and second molars, if somebody passed the oblique ridge on their access, unless there was a decay that they were trying to remove, they are way off. They just didn't know where to look for things. The most advice that I give my dental students, always start looking for where the name of the cusp is. If it's a mesiobuccal cusp, look in that area, drill down under that cusp. Don't go 5 millimeters to the left or right or up and down. That's the wrong way. I mean, there are always exceptions. I'm talking about majority of the times that you have a molar in your hand or premolar. And some teeth are honestly being underestimated as far as difficulty. In my personal opinion, one of the most difficult teeth are lower anteriors, number 24 and 25, because of their unforgiving anatomy. They have a very, very, very thin mesiodistal width. And if you don't know your tapers, if you don't know where to look for things, you can easily strip perf, as in case of some upper premolars as well. And one of the most common, not the most common, but one of the common missed canals are the second canal in lower anteriors, because as soon as we find one canal in the radiograph that we do in one direction, everything looks in the center and we think we did a beautiful job. But if you extend your axis more towards cingulum, most of them, they branch out to two canals, and that's why some of those lesions don't heal. There was simply a missed canal.
All right, thank you.
You're welcome.
If MB2, if the entire canal is calcified, would you still open the same canal and work on it.
I didn't get the question correctly. I'm sorry.
If the same canal is completely calcified, especially MB2,
Okay.
you still try to open the same canal again.
Depends who worked on it before. Yes, I always give it a second attempt because I know that I'm more equipped with instruments that gives me the luxury to challenge the tooth a little more. And simply, I like to think that I'm more experienced in opening those things that sometimes one of my colleagues could not open. But if you're asking if I run into a difficulty that I cannot open a calcified canal, what I do, the answer would be, again, depends to the prognosis. If a canal is completely calcified, but it was a reversible pulpitis case, I will definitely inform the patient. If I had CBCT and I would see the canal that is not opening, I recommend apicoectomy because you got to do a retrograde filling. You got to get into it. If there is a canal, you need to address it. There is no way to see, oh, I think it's a calcified canal, then I'll let go of it. Make sure there is one that you do not see. If you do not see a canal through CBCT, you inform the patient. If it's an upper molar case, first molar, literature shows above 90% of them should have MB2s, because I know some of my colleagues, as soon as they don't find it, say, oh, some first upper molars don't have MB2s. Yes, but look at the percentages. 9 out of 10, they do have it. You cannot say out of 10 root canals I did in upper molars, 7 of them didn't have it. No, you're doing something wrong for sure. So if you cannot find it CT, if you do not have CBCT, send the patient number. If you do not see it in the end CBCT, have to talk with the patient. If the symptoms comes back, you might need a second procedure, which is called apicoectomy. That's my approach.
Correct me if I'm wrong. As far as the percentage goes, doctor, I think 60 to 70% of the teeth, I'm talking upper molar teeth, both first and second molars, will have MB2.
The percentage is higher, depends to what tooth you're talking about. In the first upper molars, that percentage is much higher. It's around 90% that they do have it.
Wow.
In the second molar, that percentage drops to 80 some. Yeah. So most of the times we're missing them. In the upper molars, I'm talking. Yeah.
Right.
Yeah.
And we have one more question from the doctor here. Will apicoectomy tooth be a problem in the future if you happen to do implant on the same tooth years later if the tooth needs to be extracted?
Yes, we could. I mean, that's what I call step-by-step dentistry. And again, you need to have the patient on board because obviously you have finances involved. Yes, if a tooth has been done through an apicoectomy and for some reason it didn't work, obviously tooth is coming out and being extracted. And if there is presence of infection, sometimes you can clean it right away and sometimes you don't. If you can clean it right away, you can place your bone graft and close the site. And after this, it's the expertise of surgeons, not mine. I know in some cases they can do an immediate loading and do an implant and bone graft together. In some cases, they rather place the implant and they place the bone graft, close the sites, wait for a few months to see osseointegration. And as soon as they feel confident, they place the implant. So the answer in most of the cases, yes, if the apicoectomy was done, you could take the tooth out and place the implant, obviously.
Thank you.
You're welcome.
Dr. Abbas Ali, your question looks like I think you may have to retype it again. You have put down respectfully. Through years, I found out that calcified canals are. That's all I have. So please retype the question so that the speaker can address it. Okay, my question, doc. Here is the problem. I'm sure a lot of doctors would face the same thing. People come to our office with a history of severe sensitiveness.
Okay.
And the main complaint is they cannot drink cold water, nor they can eat ice cream.
Of course.
When you examine, the teeth looks good, and there, of course, there might be bruxer. We can see some cervical abrasion, and you go around the dentine, yes, it's really sensitive. Now we are stuck in the sense, would there be a fractured tooth? Possibilities are there, or is the sensitive coming from this exposed dentine? And if you do the root canal, yes, you're done and the tooth will be fine. There goes their sensitiveness issues and other things. How would you handle it? Posterior teeth, we see teeth being badly abraded.
Very good question. What I do, I usually first go back a little bit to see, because we can treat the symptoms, but it doesn't mean we treat the etiology. You got to know why the patient is feeling sensitive first. In the cases of severe class 5 type of abrasion, some of them could be related to periopathology. Some of them could be related to the trauma that the patient caused to themselves by being a very, very aggressive brushing in a wrong technique, which needs to be addressed by hygiene and general dentists to educate the patient how to basically do a correct technique of cleaning and flossing and all those stuff. If I see it's a perio related, I always involve a periodontist to see maybe they can do a soft tissue grafting, something to cover that exposed cementum that you're talking about, not necessarily the dentine, because most of those, the root is being exposed in such a way that we don't have enamel on root, as we all know, and patient feels the sensitivity. If it's just a class 5 that the root is being covered by bone and soft tissue, it's a restorative procedure, class 5. But if it's in a way that you still do your class 5 and periodontists cannot improve the condition of periodontium, there are only 2 ways to get rid of the sensitivity that patient has: either extract the tooth or do a root canal treatment. Tooth is not necessarily has the pathology for the root canal treatment, but it's an elective procedure in this matter because patient is being suffered by pain. So that's the way I look at it. I look for etiology. I try to bring other specialties to eliminate those etiology if it's related to the specialty, like in cases of recessions, in cases of exposure of roots. And if none of those could happen, then we go ahead and do the root canal treatment. If patient doesn't want it, then extraction is what it is. Before that, sometimes when there's a little bit of abrasion, I always talk them to use some of the products. Some people get answer from it, some don't, like Sensodyne. And beside, when patient comes with only chief complaint of sensitivity, I do even more control teeth. Some patients have more sensitive teeth. That's the way their teeth are. It doesn't matter if you do the endo ice test on 32 teeth, they raise their arm on single event, and in all of them, they feel that it's excruciating pain on all of them. You cannot do 32 root canal per person. Then you have to talk to other things, why this sensitivity is coming a long way. Sometimes I get consult from neurologists because these patients have other symptoms showing outside of their mouth. They have other neurologic symptoms such as pain in their neck and shoulder and so many areas. So it's very important to pinpoint what is the etiology behind the sign and symptoms that patient presents, not just treating the symptom.
Dr. Okay, again, a very interesting question here. Respectfully, through years, I found out that calcified canal can be found without numbing the tooth.
Without numbing the tooth?
Without numbing the tooth means that calcified canal should be addressed in separate visit if not found, because dentist can damage the tooth beyond repair.
I don't hear much of question or a comment, so I'm going to elaborate with a comment on it. As far as without numbing, I numb all the patients. Even if tooth is necrotic, I numb because I'm supposed to place a rubber dam and they feel the rubber dam. So I do numb in all the cases. Addressing a calcified canal in a separate session, I don't understand the question behind it. What do you mean? A general dentist is working and they couldn't find the calcified canal and they stop and they are trying to re-get back to the tooth in a second session? Sure, you could. But if what you mean by sending it to an endodontist, absolutely, they look at the tooth in a separate session and try to negotiate that calcification. I'm not sure if I answered him correctly, but that was my understanding out of his comment.
Dr. Ali, if you can readdress this question, please, if you can type it up again. I will proceed. Dr. Lopez, again, you sent a question on MB2 symptoms. Doctor did address that question though, so that I can proceed, unless you want to retype the question once again, Dr. Lopez. Thank you. My next question, Doc. Fracture of the tooth or a tooth being cracked.
Okay.
It really poses problem for us whether the tooth is cracked.
Yeah.
And my understanding is you keep probing around the tooth, and if the probe dips at one angle, yes, there might be, you have to suspect a crack or a fracture of the tooth.
Correct.
And, of course, Tim talked about CBCT and other things. Yeah, you made a very good point, and you cannot make out if there is
There
a
is
small.
no way. Those small cracks, there is no way to see in any CT.
What do you do when the patient, there are symptoms, sometimes we think the patient has cracked the tooth or fractured the tooth, but we are not able to come to the final conclusion. Yes, this is the problem. That's what has happened. How do
No,
you diagnose?
it's a very valid question, and I do run into these cases on weekly basis. If I always try to look at all the information that I can from patients and the facility within the office to come up with definitive diagnosis. If I come to a point that patient does not show any periapical radiolucency, and if I don't see any visible crack on a tooth, and patient does not have history of any kind of restorative procedure done, and patient does not have any crowns or any other issue on a tooth, and I do my optic test. The optic test, we have this very nice optical test that is very narrow. We put it on one side of a tooth, and if the shadow of the light does not pass to the other half of a tooth, it means there is presence of crack that we are missing it, because light does not travel through. So optic light test is a very valid test for diagnosing a crack in the last resort that you cannot find anything. Let's say on top of that, you don't see anything. There are two options to do. Have the patients come back and adjust the occlusion, because sometimes patients have different bites. In one area, they're pressing more force on it, and their PDL is basically more inflamed, and that's what they're feeling. And as soon as you touch the tooth, they say, ouch. So I adjust the occlusion, have them come back in a week. I ask them if the symptoms got better or worse, or no difference. If the symptoms is still present, we can always get into the tooth, and sometimes as soon as you get inside the tooth, you see the cracks on the margins. There's hiding there, basically at the CEJ. But most of the cracked teeth that I see are the ones that some sort of dentistry has been done. There was a big MOD filling on a tooth. There was a big onlay on a tooth. Or in some cases, there was some crown on a tooth and pre-existing crack, which was not caught on the right time, and it just progressed. And now that you go inside, and general dentist wants to save the crown, that makes the job more difficult, because once you remove the crown, you can see all the margins much better. But I always try to accommodate my general dentist. I go through the crown, I start cleaning internally to get closer to where the margin is. But the big but is that I inform my patients there is a chance that I might be missing the margins because crown is on top of it. But if I go inside any tooth that has pain and you're suspected of a crack, I don't see any crack under the margins of the crown that I did not remove, I will go ahead and finish the root canal and do the build-up internally myself to make sure at least we got rid of symptoms and that crown would not progress any longer. But I inform the patient that they need to come back every 6 months for reevaluation. If you see periodontal pockets being developed, we can do more, not more advanced, more aggressive type of exploration by raising a flap. You raise a simple flap, you see a crack because you will see a little bit of bone loss. You could see it, literally you will see it. But that optic light that I told you is one of the best friends in those cases that you're not sure if there is a crack or not. Because if there is the smallest crack, the light will not travel to the other side of the tooth. It doesn't illuminate. We call it illumination test.
Thank you, Doc. And the other problem also I'm kind of finding kind of very difficult as a general practitioner. We could handle it. It is on the lower molar, usually first molars, distal canal with one more, you can say, extra distal canal. It is a C-shaped canal.
Yeah.
Very skinny. How do you approach those canals? It's a very, very, I cannot even use the rotary instrument, very skinny. How do you instrument it?
Yeah.
And it kind of takes a very nasty curvature too.
Yes, yes. First of all, the C-shaped canals are most common among female Asian populations. Not that other populations could not have. Research shows the biggest group of patients who do have such an anatomy are female Asian patients, that they have C-shaped canal in their lower molars. In the C-shaped molars, if you have CT, again, it's a very, very, very useful machinery. If you do not have it, I suggest if you see a C-shaped canal, please stop. Do not explore more. Either send the patient for CT somewhere that you can gain more information to see how many portals of exit do you have. C-shaped canals come in different variety. Some of them are one C-shape with one exit of portal apically. Some of them several. Some of them get connected to the other canal. Some of them don't. So in this kind of cases, I find the main portals of exit. I prep them with my rotary and hand instrument. The rest of them I clean with ultrasonic and rounds and rounds and rounds of irrigation. And after that, I obturate with warm vertical technique impaction. The major portals, I cut down the gutta percha the last 3 minutes. I impact. The rest of them, I do with my backfill and I impact, so I cover all the area. That's what I would do.
Thank you.
You're welcome.
There is a message from Jesse from RF America, doctors, for our benefit. He says, we have a carry detector camera that comes with a trans illumination lighting that may help you detect a crack.
Yeah.
It's called as Inspire.
Yeah, that's the transillumination test that I told. Any basically instrument that you could employ for such a thing, it will take care of it. I don't mention any particular device. Any transillumination device would do. But the light of your mobile or the light of the chair is not that. These are the instruments that have specific tips that you can place it on a tooth, not just turning the light unnecessarily inside patient's mouth.
Okay.
Yeah.
This is the next question I was discussing you prior to the meeting, and I have a patient. This is an upper molar. I think it's tooth number 2, and the root canal I sent him to endodontist. It's a beautiful root canal, and he sure came back after good 1 year with discomfort.
Mm-hmm.
And distal probing, it went up to almost like 8 millimeters pocket on the distal side. When I took the X-ray, bone was kind of short, badly broken up. Periodontally, it was broken.
Okay.
My question for you is, when you talk about endoperio lesion, how am I to know where this infection came from? Is that the perio was the initiative factor or the endo was the initiative factor? How was the crack?
So let me ask you this. When you opened up the tooth was cracked?
No. He had a crown on the tooth.
Okay.
And first I sent him to endodontist for the root canal, and it was a very well done root canal.
Okay.
Classic root canal. And when I think he returned after a year or so, when I checked the tooth, he had some discomfort on the distal side.
I got it. Yeah.
When
I understand.
8 millimeter pocket.
Yeah. If a root canal is done properly, again, we can only code on what the literature says. If it's an initial root canal, 93% chance of success. If they found all the anatomy, if the CT doesn't show any deficits in the treatment, then you have to look at the perio reasons. Periodontist should have an evaluation on that. Maybe it's periodontium. It's not the tooth that is causing that pocket, which I know periodontists have pocket elimination procedures in the places that the pocket does not have the biological width is not being respected. You have to look at other factors. You have to look at your own restorations. Did you violate the biological width or not? Where did you end up your margin? Did the patient, what was the condition of periodontium before doing the root canal and crown? All of these factors, if they're noted down and documented, leads us to a very, very precise, definite diagnosis. In the case that you are referring with the assumption that there was no pocketing in the begin with, and if the crown that was placed after the root canal was done properly and biological width was not violated, and with the assumption that the root canal was done in the best standard possible, then the only suspicion is referring to periodontist to see what is the reason for this pocket. They might have a perio disease. But if one of those items is questionable, it could be related to those two.
Right. Also, would you suspect any fracture?
Fracture, we do always suspect, but again, we get into it, we have to see it. Because most of the fractures are happening in the coronal third. You rarely see that a fracture happened in the apical third that you're missing it. Because bone is supporting the tooth in that area, remember. Wherever fracture happens, they start losing periodontium around it. That's why in fractured teeth, is highly recommended to get the crown ASAP, because that crown gives you full coverage, 360-degree support, so it does not allow for the crack to progress.
Okay.
Yes, there is a possibility. You cannot say there is no possibility at all.
Doctors, we have another 3-4 minutes. Time to, if you have any questions, please post it. And I do have one more question coming up. And after that, if I don't have any question, we're going to close it up. My question, Doc, hemisection or root amputation, what is your take on it? Mainly, I'm concerned about the prognosis.
Yeah. Hemisection in these days that we have the implant dentistry is becoming less and less favorable, because the outcome, as you said, is not as predictable as implant dentistry. Root amputation, in the other hand, depends what you call root amputation, because apicoectomy is root amputation, but only in the apical third. For that, it has a predictable outcome if somebody wants to keep the dentition. Again, you have to look at the scenario and all-around treatment plan inside patient's mouth. If patient is healthy, if patient is not healthy in the sense that they have autoimmune disease or they have anything that can compromise them with more aggressive surgery or not, in those kind of cases, you want to hold on to their tooth with all the, even know that the prognosis might not be as favorable. If somebody really doesn't want to lose the dentition, with understanding that the prognosis could be questionable. Throughout my career, I've only done 2 hemisections, honestly. Most of those tooth goes towards implant dentistry, because hemisections usually happens in the lower molars or upper molars. And basically you're losing 1 or 2 roots, and you cannot say that that tooth is going to be as strong. But some people, they hate to lose teeth, and for them, yes, we can go ahead and potentially do a hemisection. But when it gets to that stage in private offices, since we have capable surgeons around us, usually we refer them to a surgeon for extraction and implant. But is it doable and possible? Yes, of course. But for root amputation, again, if it's an apicoectomy, I go for it. But some of the cases you have to amputate the root because of other reasons. Somebody perforate the root in the mid-third, and there's not much you can do, and you cannot maneuver around that ledge, and the pathology keep in 6, and it's only the mesiobuccal root of the upper first molar. Palatal and distal buccal, they're strong enough to hold on to the tooth. Yes, we could do the root amputation and place bone graft.
Thank you, Doc.
You're welcome.
My last question would be, the 2 canals in lower bicuspids and cuspids, what would be the percentage like? Because invariably bicuspid, we can miss that second canal.
Yes, in the lower bicuspid or upper, which one you're saying?
On lower bicuspid.
Yeah, lower, they have lower percentages of having 2 canals, but I treated lower bicuspids that they had 3 or 4 canals. We call them mini molars. Let me give you a general rule of thumb. If you're looking at your biting and PAs, if you can trace down the canal in the coronal third and all of a sudden things get disappeared, always suspect that you're getting bifurcations. And in those cases, you have the second canal. Whenever things get disappear, it means something is happening. Most of the cases I start tracing, that's why I do 3 different angles of PA in every single tooth that I do. I like to see every 3 views, mesially, a straight shot, and distal shot. If I see in 3 of them, I see that the canals are getting disappeared, there is usually indication that something else is there that I'm missing. And we go, when we do our axis, we look at the general rule of anatomy, things supposed to be centered. If not, they should have a counterpart. Example, when you're opening a lower molar, when you find the mesiobuccal, usually in the, if you're working on tooth number, let's say 30, it's on the upper right side of a tooth, and the counterpart is exactly identical towards the lingual aspect, which is the mesiolingual, and your distal canal is very much centralized. So we always go with the rule of centralization. Things got to be centered.
Thank you, Doctor. Again, doctors, if you don't have any question, I'm going to close it up. Thank you very much. It was a great presentation. It was a candid discussion. That's what I like about, and I love to discuss with you more.
Anytime. It's my pleasure to have your audience, and thank you for inviting me. I appreciate it.
Thank you very much, and thank you very much, Tim, and so do Darius. We're going to see you all in the next webinar. Thanks a lot.
Bye-bye.
Have a
Thank
wonderful
you.
week, and we will see you next time.